So now discuss regarding complication of massive transfusion protocol. One of the important complication of massive transfusion protocol, that is coagulopathy. We minimize this complication by using pressurized rapid infuser with an inline warmer that will warm the blood components so that the hypothermia component can be minimized. We are giving packed RBCs to treat the acidosis component. So whatever derangements are contributing to bleeding, we are trying to address them. The next complication is TRALI, transfusion related acute lung injury. Now, TRALI is characterized by the occurrence and worsening of hypoxia and non-cardiogenic pulmonary edema with bilateral interstitial infiltrates on X-ray during or within 6 hours of transfusion. Although delayed cases may be occur up to 72 hours later. Now, the clinical features of TRALI are dyspnea, hypoxia, fever, hypotension or hypertension. Now, regarding investigation, this is the X-ray showing TRALI, and the second thing is the BNP level will be normal in TRALI and the treatment will be supportive only. Now, next is TACO. TACO means transfusion associated circulatory overload, which means fluid overload. TACO is a common and under-recognized transfusion adverse reaction. The risk factor include old age, renal failure, pre-existing fluid overload, cardiac dysfunction, administration of large volume of blood components, and an excessive rate of transfusion in relation to the patient's hemodynamic tolerance. TACO results in dyspnea, hypoxia, bilateral and predominantly alveolar infiltrates on X-ray, frequent systolic hypertension, and elevated brain natriuretic peptide, that is elevated BNP. Okay, fever may also exist. Now, the treatment requires stopping the transfusion and administering oxygen and diuretics. Now, the next complication is hyperkalemia. Because patient's RBC was stored at low temperature, they might be near their expiry date. So therefore, their sodium potassium pump have shut down due to depletion of glucose. So if the pump will shut down, they will not be able to send potassium inside the RBCs, and therefore the blood potassium level would be elevated. So hyperkalemia occur. Now hyperkalemia will contribute to diastolic arrest. So if there is a bradycardia post MTP, then it is hyperkalemia that is occurring in this patient. Now the next complication is citrate toxicity and hypocalcemia. See, citrate, which is commonly used to anticoagulate blood components, but it chelates calcium, which lead to hypocalcemia. Now, hypocalcemia manifested by circumoral paresthesia and change in cardiac function may result from multiple rapid transfusion. Although citrate is quickly metabolized by bicarbonate, calcium infusion may be required. Now, sometimes there is a development of stridor in the patient, but the chest is clear. The sounds are coming from the upper airway because there is a laryngospasm developing in a patient due to hypocalcemia. Now, another thing hypocalcemia is doing is tetany occurring in a patient. Now, the next complication I will talk about iron overload. See, each unit of RBC contains 200 to 250 mg of iron. So, with MTP, iron accumulation that is left untreated will affect endocrine, hepatic, and cardiac function. Death may occur from cardiac failure or arrhythmias. Prevention and treatment of this frequently underreported transfusion adverse event rely on careful monitoring and iron chelation. Okay. Thank you so much for listening, and we will continue with another topic.